Hello and welcome to our fourth episode of For the Communities Grand Cycle at Under 8 Minutes. I am your host Chinmy Kumar from the Asia Pacific Regional Learning Hub. In our last episode, we have talked about human rights as the foundation of our work. Today, we are focusing on the other side of the coin, which is gender. We know that the gender related barriers can make or break the health programs. And to help us navigate the must knows of gender in GC8, I am joined by Thea Willis, Senior Technical Advisor for the Gender at the Global Fund's CRG department. Thea, welcome to the podcast.
Thank you so much. I'm thrilled to be here.
Let's dive straight into our three critical questions. Thea, what is new or significantly different in GC8 when it comes to gender and removing gender related barriers?
All right, thank you so much. So I'm going to tell you about four really important changes. I know three is usually the magic number, but you get an extra bonus one with gender. So there's four important changes to tell you about. And all of these changes have been designed to really make HIV, TB, malaria programs more effective and to improve health outcomes. So number one, for our large portfolios, there's now a mandatory assessment of barriers to service access, particularly gender equality and human rights barriers. So many countries have already been assessing these barriers, but for the first time in the large portfolios, it's really mandatory. And this means that countries really seriously need to keep looking at who's being missed, why they're being missed, and what's stopping those people from accessing services. And these assessments absolutely have to include the meaningful engagement and lived experience of communities for gender, particularly women, girls, and trans communities, because their experiences and input is critical evidence of what those gender barriers are and what the solutions are. So that's number one. Number two, in the modular framework, the Global Fund modular framework, which has all of our investment areas, there is for the first time a gender module, and it's got really clear investment areas based on evidence. So we think this is going to help us move from gender, which is sometimes not always the kind of broad commitments, into really practical program areas. And these program areas include adapting health service delivery so that it's safe and respectful for women and girls and transgender communities. And we know this getting service delivery is really important, particularly with this rapid drive for integration. And then program areas about strengthening women's health decision-making power, removing their financial barriers to care, improving men's care-seeking behaviour, and preventing and responding to gender-based violence. So that's number two, new gender module in the modular framework. Thirdly, there's a new HIV program essential. And program essentials are the critical evidence-based areas that need to be prioritised across all effective programming. So we have a new one relating to gender, and this is that intimate partner violence, so identification, first-line support and care, and post-rape care need to be integrated into HIV prevention, testing, treatment, and care services. So progress towards this program essential should be reflected in the funding request. And this is the bonus one, number four. There are new gender equality and human rights matching funds for eligible large portfolios. And these matching funds mean that there are additional financial resources available for countries when they include a strong commitment and have strong focused investments in gender equality and human rights barriers. So communities can check, is their country eligible for these matching funds? How are they going to be planned? How are they going to be spent? And how is that going to advance gender equality and health? Thanks.
Yeah, thank you so much for the bonus. During this time, bonus is going to feel good. But it's clear that GC8 is just not, is demanding more than not just ticking box when it comes to gender. But when resources are tight, things get missed, right? So Thea, in your experience, which aspect of gender programming is often overlooked, and what should communities be prioritizing as this heads into the GC8 negotiations?
That's such a great question, and it absolutely can't be a tick box exercise. And all those changes and evolutions that I spoke about in the first question are designed to really make sure it's integral to the way that we're thinking about health service design, delivery. Okay, so what's often overlooked? I could talk all day about this, but I'm going to flag a few things. Firstly is around integration. I mentioned this briefly before, but integration is rapid. It's happening rapidly. And, we often very rightly think about how we can make sure that criminalized, stigmatized populations, key populations, are not excluded. We also need to think as well about how women and girls are not excluded from that rapid drive for integration, and how we can make sure that integrated services really meet their needs. So if an adolescent girl or a young woman goes to a health facility, for PrEP or contraception, HIV testing, and is shamed or stigmatized for being sexually active or for having sex, is told she's promiscuous, is treated disrespectfully, then she doesn't go back to that health clinic, not only for sexual and reproductive health services, but for any other health services. And so we really need to be thinking about how we can make sure that integrated services can really work for women and girls and key populations. The second thing I would flag is around antenatal care. So antenatal care is a critical entry point for so many health interventions and outcomes, maternal health, but malaria prevention, HIV testing and treatment, preventing vertical transmission of HIV, and then loads of child health, immunization, newborn care. And we need to obviously make sure that the supply side is there, so those services are available. But we can't always focus only on the supply side, and that's where the gender dimension comes in. Even where antenatal care services exist, we know that many women can still face gender-related barriers to attending early and consistently. Disrespectful care, obstetric violence is still horrendously common. Lack of confidentiality. Women need permission from their husbands, or their husbands make decisions about antenatal care. Really long waiting time. Lack of women's access to finances so they can get transport and other costs. So the issue is not just is the services there, that's an absolutely critical issue, but it's also whether women can actually use those services safely, consistently, and with dignity. And so I would say when thinking about investments in antenatal care as a platform for so many health interventions, you need to think about the gender barriers and the gender solutions that can help women really make the most of those services when they're available. The second area I would mention is intimate partner violence. Intimate partner violence is endemic. It's such a huge issue still for mostly for women and girls. And it cross-cuts so many health issues. And the one I want to flag today is vertical transmission of HIV. There is evidence suggesting that intimate partner violence might be responsible for up to 1 in 8 pediatric HIV infections in sub-Saharan Africa, but intimate partner violence is rarely treated as central to strategies to eliminate vertical transmission. So I would say really think about how the ways in which this horrendous practice really manifests across lots of different health gaps and issues that we still are grappling with. And then finally, I would talk about men and gender, because we don't do that enough. And we know that gender norms can discourage men from seeking care early. Look at TB, HIV, staying in care or losing men to follow up is too common. And there are these gendered expectations around toughness, around having to be the breadwinner, not wanting to appear weak. And we know that this can delay health seeking, testing, treatment. And this has consequences for men's health, for their whole households, for families and communities. So I really would encourage us to think about some of the solutions to persistent issues in men's healthcare around gender. But the final point I would make is that all of these issues have the same root cause. So they're manifesting in different ways for different people across different diseases, but they have the same root cause. That's gender norms and gender discrimination. It's affecting health-seeking behavior, health decision-making power, access to health services. Tackle that root cause in a holistic way, and you'll find solutions to so many of these persistent health issues that we're still grappling with.
Thank you so much, Thea. These are really critical points, and it will definitely help communities. And prioritizing the overlooked is a bold move, honestly. And but like advocates also need evidence. So Thea, for those listening and who are right now or like going to be into the CCM meeting, what kind of data or arguments can communities use to effectively advocate for gender integration in their national HIV, TB, and malaria responses?
Thank you. Also, such a really important question. And I think communities should be really confident around this when it comes to gender. Gender integration is evidence-based programming. It shouldn't be treated as a nice to have, and it certainly shouldn't be held to a higher evidence standard than everything else. There is already a huge wealth of evidence around the interplay of gender and health. There's program data, there's tons of academic research, there's randomized controlled trials, there's program evidence. Importantly, there's community-led monitoring, and there's lived experience. That is critical evidence. And all of this shows the interplay between gender and health outcomes. So I would suggest maybe three things that communities can use. Firstly, really dig into the program data, because that's what speaks to the decision makers that are making program decisions. Look at that data. Where are those services not reaching people equally? You know, are adolescent girls and young women still facing high HIV risk? Are pregnant women missing ANC, malaria prevention? And what are those gender barriers that are stopping them from attending and staying in ANC? Are men being diagnosed late for TB or being lost to follow-up? Are key populations avoiding services because of violence? The program data can tell us this. So use it and then ground the solutions in closing those programmatic gaps. I think that really speaks to the program priorities. Secondly, community evidence is absolutely critical. Community-led monitoring reflects people's real lives and lived experience. It's like gold dust. So we need that information, and that needs to be fed in. We can see where the gaps are, but importantly, that information also tells us why those gaps exist. And we need that evidence to design programs that really work in real life for real people. And then finally, I think the investment and impact argument is really critical. So show how these gender barriers are either making people more vulnerable to diseases or stopping them from accessing and staying in services. And then how funding and removing those barriers can improve uptake, retention, adherence, prevention outcomes, quality of care, you know, improve across the whole spectrum. And so I think just really being confident that there is a wealth of evidence around gender there, and that gender equality is not separate from impact, is part of how we achieve impact across HIV, TB, and malaria programming.
No bonus this times, but like the points which you have shared are really critical, and this is definitely going to help communities. Thank you so much, Thea. Like you have shown us that addressing gender isn't just a social goal, it's a clinical and technical necessity if we want our health systems to work for everyone. To our listeners, gender equality is the key to reaching the unreached. We will request you to please share this video with your gender champions and community networks. Make sure that the gender section of your funding request is strong, funded, and community led. Subscribe to our YouTube channel, to our newsletter page, and please don't miss the single bit of the podcast series. I'm Chinmy Kumar once again. Thank you so much for joining, and see you in next 8 minutes.